Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Mariposa Community Health Center for hosting today's session, Pediatric Epilepsy with Dr. Carter Wray. Carter Wray, MD, spent 12 years at Oregon Health and Science University as a pediatric neurologist specializing in managing children with medically intractable epilepsy. This included directing the ketogenic diet program as well as surgical interventions. He directed the Pediatric Neurology residency and was the associate director of the Pediatric Neurodevelopment Disabilities residency. Prior to that, he did 2 years of training in pediatric epilepsy at the University of Washington Seattle Children's Hospital, as well as 5 years of pediatric neurology residency at the University of Colorado Health Sciences Center. And with that, Dr. Wray, it's all yours.
Thank you so much. I jokingly increased my title from neurologist to epileptologist as one of my ICU colleagues decided that was a better 10-cent handle, not a simple, just a regular brain doctor. But yeah, I just really like seizures or really like taking care of children with seizures. And so talking about them is great. And normal disclosures, I may be discussing off-label use of medicines if people ask questions about treatment, because much of that is off-label. Accreditation we just talked about. So we're going to talk about what seizures are and what is epilepsy. And then really focusing mostly on what specific seizure types are, and then what are things that look like seizures, and then what do we do to try and work that up and sort them out. So the seizure itself is the stereotyped transient disturbance in brain function due to discharges. And so stereotyped is really the key. Does it fit a pattern that brain activity does? And so that could be a positive thing so that they could do a movement that you can visualize and you can describe as a provider, or it could be an absence of their normal function. So certainly lots of people call that absence seizures, which is a French term that is unfortunate. Well, it is used often by different people to mean different things, but there can be hypomotor or decrease in motor activity seizures that can actually be different from absence. And then unfortunately for us as providers outside of the child or adult's body, they can have feelings that are due to the seizure that we can't see. So those subjective things can be really, really tricky. Usually we don't become aware of them until they go from a subjective event to then having something like a positive abnormal movement. And then you realize, oh, there was something that was going on before the child started stiffening, moving, or jerking. And then epilepsy is the recurrent unprovoked seizures that can be symptomatic, meaning it's a symptom of something underlying going on with the brain. So that could be that the brain grew abnormally, structurally, could have had a stroke in it, which in young children is actually fairly common. And then there's also genetic causes and other things like that. But the vast majority of patients with epilepsy, we don't understand why they have it. So 70% of patients don't have an identifiable cause. So yeah, most of the time it's idiopathic, meaning I look like an idiot because I don't know why they have a seizure. But yes, oops. And then most often the children are normal before the seizures start. The kids who are abnormal developmentally before the seizures start, that's usually an indication that there was something either structurally or genetically wrong where their brain has not been growing normally. But most kids are what we consider neurotypical. And then EEG is certainly something that often helps us sort out the epilepsy type because there's certain patterns that certain epilepsy types have. So this is a big slide of classification, and you don't need to worry about the majority of it. But the reality is there can be seizures that come from one part of the brain, and those can be differentiated from those from the whole brain. So the whole brain seizures are much more common in children, whereas partial or just some of the brain it is much more common in adults, but a lot of children have focal seizures. And then unfortunately, there are the unknown where it's coming from seizure types. So we'll break down that some seizures start focally and then progress to bilateral or whole body involvement where they lose consciousness. So that is what we call secondary generalization, whereas children often have seizures that are whole brain from the onset. So generalized seizures can be tonic, meaning stiffening followed by clonic, although they could also be clonic followed by tonic or just straight tonic. So absence, we're going to talk about a little bit, where these are the staring seizures, some of which are classic in one way or another, and then others can be more unusual, whether that's weird features like they can jerk with them, they can have their eyelids do funny things with it. And then myoclonic is just a single jerk, which can be jerk before falling down, or atonic, loss of muscle tone, or they can go a single jerk into a tonic or stiffening seizure. Clonic means rhythmic jerking. Tonic, as I've already said, is stiffening, a lack of tone, tonic. And then epileptic spasms, I actually think that I did in infantile spasms, which is most kids who have spasms are infants or under a year of age to the Mariposa group. And then, yeah, there's some weird stuff that just doesn't fit the classification. Anybody willing to type into the chat what movie this fine quotation is from? For those of us who are around 50 or older, you might remember this classic reference to the Europeans. And the reason I reference the Europeans is that Grand Mal is just French for big bad. And unfortunately, Petit Mal is just French for little bad. And the badness of the seizure is certainly something that is very non-descriptive. So I really greatly encourage families and providers to say, what did they see, and not label it as, oh, he had a grand mal seizure, because that doesn't really help me understand anything other than most likely the child had a convulsion. Whoops, I am not seeing the chat, but for those of you who are movie buffs, this is Ferris Bueller's Day Off, because he doesn't uncover. I also dislike the term GTC. I jokingly say that it means you've got to call neurology. It's very hard to say, does the seizure actually start whole body generalized? Does it actually go from the tonic stiffening phase before the clonic phase? So these are questions I have as a brain doctor. Are you talking about a primary generalized seizure or a secondarily generalized seizure? And most primary care providers and most emergency room physicians actually don't care, and you don't necessarily need to care. But I just think that using the word GTC is sort of like grand mal. It just doesn't tell me a whole lot. And then so which phase came first? Is it generalized clonic, then tonic, is something I often wonder about. But really, saying that the child convulsed is often the most helpful thing. And then again, if you want to use terms, say that the child got stiff, you say the child had rhythmic jerking, and then you could say whether or not the child had singular muscular jerks at the onset or offset. So thinking about different seizure types, they can run together in herds, and the different epilepsies tend to have them. So if we say that the absence seizures, the staring ones, are the turtles, the generalized convulsions of tonic and then clonic are rabbits, and then elephants are a myoclonic jerk. If we take seizure syndrome number 1, where a kid has a generalized convulsion, which in teenagers, they almost always show up at the emergency room due to the generalized convulsion, but they've also been having staring seizures for a while. Well, that actually could be something, either childhood absence epilepsy, where 10% of the kids have rabbits, or more commonly, juvenile absence epilepsy, where 85% of the kids show up with a convulsive seizure, but also have staring seizures. The other epilepsy syndrome, where, again, most of the teenagers show up with rabbits or convulsing. Some of them, about a third, will have staring seizures. But by definition, they all have elephants, but many of the parents don't realize that those are seizures. That's a condition we call juvenile myoclonic epilepsy. So certainly, does this child have just one seizure type? Almost always the GTCs or the convulsive seizures are the ones that bring the child to medical attention, but asking about, are there other things that might be more subtle, such as staring or just whole body jerking without losing consciousness, can really help us figure out what's the condition the child has. One way to think about seizures is how long they are. Some seizures are super short. By definition, myoclonic seizures are the shortest because each individual seizure is just a fraction of a second. But some people will go into myoclonic status, and that's really, really bad. Infantile spasms are usually between 2 seconds and 6 seconds long. Absence seizures, we define as starting at 3 seconds because you can't really tell externally is the child seizing until it gets as long as 3 seconds, and most are under 15 seconds. Tonic seizures are stiffening, lasting usually between 10 seconds and a minute. For the children who have spasms, as they get older, the spasms may stop being clusters and become individually longer seizures. And so some people actually even call between 5 and 10 sections a tonic spasm, but really it's just sort of slicing up the group with more fine terminology. The kids who do have stiffening that evolves into rhythmic jerking, that's usually going to be a lot longer. So usually the first 30 seconds is the stiffening phase, and then they start rhythmically jerking, but it's usually done within 3 minutes. And then partial seizures can be longer still. often, particularly if they do secondarily generalize. So they start in a part or a focus of the brain, and if they spread to the whole brain, then they often last a couple of minutes. And then febrile seizures are going to be the longest, typically, and fortunately, the least problematic of this cohort. So speaking of febrile seizures, a simple febrile seizure, I usually use the number either 6 or 5 and say they start at 5 months and last until they're 5 years, or they can start at 6 months and last until they're 6 years. Certainly, if they start before 5 months, I get worried. If they last beyond 6 years, I'm worried. But by definition, they have to have a fever. And this is a term only to be used for developmentally normal kids. So kids who are cognitively abnormal are not likely having seizures that are in the febrile component. They can have seizures with fevers, but it is not the same thing as saying febrile seizure, because by definition, with a febrile seizure, we are reassured that this is likely not a worrisome disease pathology. They are much longer than typical seizures. And like I said, we don't consider it status epilepticus where with febrile seizures unless it's 15 minutes, whereas with other seizure types, it's 5. So 15 minutes is an incredibly long time. The parents will likely have freaked out beyond their own ability to compensate, and that's totally normal and totally typical. But the good news is it doesn't hurt the child. The whole body should get stiff or rhythmically jerk from the onset. They should have a short postictal phase. So after the seizure, they should wake up much quicker than they would after an epileptic seizure. So anything that doesn't really fit these above can be lumped into complex febrile seizures. So that would be more than one seizure within 24 hours. And that does not worry me as a brain doctor hardly at all. If it is more than 15 minutes, but again, under 60 minutes, we don't think that there is an increased like of brain injury. So 60 minutes is incredibly long. If they're focal features, that would be the one thing about a complex febrile seizure that would make me think about getting an EEG. If it's a generalized seizure that fits all these criteria, do not need to get an EEG. It's not likely to help. And quite honestly, about 3% of people have abnormal EEGs. And so just having an abnormal EEG does not necessarily help you treat this child any better. If the child has a prolonged postictal phase or is just not waking up after the seizure, then I really worry about meningitis. So is this a child who's having a seizure with a fever because they have meningitis and they're not waking up because their brain is infected? So certainly thinking about lumbar puncture and further testing would be very appropriate for those kids. And then do they need blood tests for electrolyte abnormalities or other potential causes? The one thing, again, that does not make this a complex febrile seizure is if the child is developmentally abnormal. In which case, if the child is developmentally abnormal, their brain is probably different in such a way that the fever has provoked the seizure and they're declaring that they have epilepsy. So that is a kid who, if they're developmentally abnormal, yes, getting an EEG and more likely needing a referral to a neurologist. But with the other stuff, reassurance is key. So don't require tests. They don't need imaging. Like I said, I would do an EEG if they're focal or if the kid's developmentally abnormal, but a routine febrile seizure does not require any tests. They need to be reassured. Unfortunately, half of the kids who have a febrile seizure will have a second, particularly the younger kids at onset. And if they have a second, then even more of them are going to have a third. So they're definitely kids who have frequent febrile seizures. Unfortunately, you can't really prevent them. Antipyretics usually A, don't work, and B, make the parents feel really guilty that they didn't get the Tylenol into the kid quickly enough. And the answer is you can't get the Tylenol quickly enough. Usually the seizure happens right as the fever is going up. And so you can't really predict it ahead of time. Some people have tried just giving seizure drugs, particularly benzodiazepines, when kids are sick, and the side effects are worse than the potential benefit. So giving drugs doesn't actually help eliminate them. It may reduce it a little bit, particularly phenobarbital, but the side effects of phenobarbital are yucky. And so I just strongly encourage patients and the kids are normal unless the kids have over 60 minutes of seizure. So it really has to be much, much, much longer, even the 15 minutes that we tell them. That's when the families should either should call 911, would be for a 15-minute febrile seizure. For a shorter febrile seizure, they can stay at home. So when do seizures happen? So certainly focal seizures happen throughout the lifetime. There is a higher number in the sort of infant period because that is often when kids are declaring that they're going to have epilepsy from a focal brain injury, like a stroke that happened in utero. And then certainly as life goes on, most adult seizures are focal, particularly older adults. Infantile spasms are in infants. Febrile seizures, like we said, 6 months to 6 years, or 5 months to 5 years, however you want to cut it. Absence, we have two humps where there is something we call childhood absence, which happens usually in sort of kindergarten, first grade, second grade kind of kids. And then there's a teenage cohort that overlaps with myoclonic epilepsy, as we'll talk about in a second. Tonic seizures, usually in children who are a year of age. Myoclonic seizures, there's a huge spike in that in the teenagers. So juvenile myoclonic epilepsy and juvenile absence epilepsy are very, very similar conditions. And then convulsive seizures that start whole brain to have sort of mid-childhood onset. So infantile spasms are a very unique seizure type. They're short, but they fortunately occur in clusters. So after they have one seizure, then they tend to have another one a few seconds later. And it can be a mixture of different abnormal movements. And most commonly, when the child is going to wake up or go to sleep, they tend to have multiple clusters a day. So these are really easy to videotape because they've had one cluster. The parent should know to get their video function up on their phone so that partway through the cluster they can record it. There's often a post-ictal or end of seizure cry. Oops, and I have commonly on going in and out of sleep on there twice. So here's a video of a child. This is a more subtle one than the video I showed in the last talk I gave, but that is the spasm right there. And 2, 3, 4, 5, 6. There goes the next one. So happening in recurrence, usually, like I said, every 5 to 10 seconds, they're going to have another one. There's a third. And so those spasms can be more violent than that. They can be subtle, but those usually happen in children who have had some kind of developmental problem. So they're often developmentally impaired prior to the onset, but when the seizures start, they often lose the skills that they've had. So kids who were making eye contact may lose eye contact. Kids who were babbling may stop making language. So that kind of developmental regression with those weird movements should be a red flag of this is likely a spasm. Again, most spasms are symptomatic due to something like a brain injury that happened during birth. Kids with Down syndrome have them more often, as well as kids with tuberous sclerosis. You're not going to be able to recognize most of the other rare genetic stuff without sending them to somebody for much more thorough testing. So absence seizures, as I mentioned before, 3 seconds is sort of the minimum. They are usually done within 10 seconds. They stare. Usually their eyes are straight ahead during the staring. Sometimes the eyes will roll a little bit up. For classic typical absence, which usually is the childhood onset variety, they just go boom into the seizure and then boom, they're out of the seizure and they're back to normal. They can have some automatic behaviors. Blinking is very common, much more common than lip smacking. And then finger picking is pretty rare. And when it happens in absence seizures, it's almost both hands are always picking together as opposed to focal seizures where they can pick with just one side. Childhood absence kids have lots of these. This is not one seizure every once in a while. It is multiple per day until they get on therapy or potentially outgrow it, but that usually takes many months. Hyperventilation is the key. The families will almost never say that they're hyperventilation induced, but this is something you can do in the clinic to pretty much nail the diagnosis. If the kid comes in, they say they're having lots of staring spells and you have them huff and puff for 3 minutes, you're going to get 2/3 of the kids to trigger a seizure, and then you're going to know exactly what you're dealing with. Like I said, post-ictal, there's typically none. Atypical absence are a little bit fuzzy. Sometimes they're longer than the 15 seconds we see above. They often have them less than dozens of times a day. Most atypical absence happen in kids who have other seizure types. And so it becomes a question of which seizure type really matters. But certainly atypical absence is less likely to happen on its own. So here is a kid who's getting hyperventilated and they're doing their huffing and puffing. You don't need to have a pinwheel, although pinwheels are fun. You can just hold a piece of tissue paper in front of them and have them puff it so it goes up in the air, and then boom, he has gone into a seizure. He's blinking, he's lip smacking, he has no idea what you're saying to him We often give words, and now he's done with his seizure and he's looking around wondering why he's holding a pinwheel. Some kids will even go back to then puffing on the pinwheel because they're fully back with it and they keep doing the thing they did before. So this is something where, like I said, you can elicit it and clarify the diagnosis in the majority of childhood absence epilepsy. So childhood absence epilepsy is certainly one of the more common types. Like I said, 5 to 6 years old is classic for when they start. You don't really need to worry about the EEGs and stuff. But these kids are cognitively normal. That is very different from the kids who start having staring seizures earlier, where almost all of them have intellectual disability. And the kids who are younger also have other seizure types. So they often have stiffening seizures. In fact, some people say by definition, if they're Lennox-Gastaut, they have to have stiffening seizures. About half of them will have drop or atonic seizures and then have myoclonic jerks while awake. So the intellectual disability, certainly with these kids, if it's just staring, I don't really worry that much about it. If they're doing other things worrisome for seizures, then yes, absolutely send those kids for EEG and neurology consultation. The childhood absence group is the group that's most likely to have just the staring and not have any other seizure type, which is good. Only 10% of those kids have convulsives, which is wonderful because I don't like kids having convulsive seizures in general. The teenagers, both juvenile absence and juvenile myoclonics, they start older than these kids. Usually they are cognitively normal. If you really drill down on it, they may have more impulsivity, more ADHD, more subtle cognitive stuff. But these are kids who learn to walk and talk at a year of age and are otherwise fit within the normal group of patients that you have. A third of the kids with absence seizures are going to have myoclonic jerks, whereas by definition, if they have juvenile myoclonic epilepsy, they all jerk. But the majority of these children show up in the emergency room with their convulsions. But in retrospect, you could find out that they may have been having staring seizures as well. Oops. The EEG, for those of you who take general pediatrics boards, this is the one EEG I've heard about being on the pediatrics boards. It's just showing that in every 1 second, they tend to have three spike and waves. So this 1, 2, 3 things happening within a second is a 3 hertz spike and wave, which is the classic childhood absence. Here's the seizure starting, and then 1, 2, 3, 4, 5, 6, 7, 8 seconds later, the seizure is done, and by 9 seconds, their brain electricity is back to what it was beforehand. So while you don't need to worry about EEGs much, ordering one, it is a slam dunk diagnosis for the majority, the vast majority of children with absence seizures. So if a kid is staring and their EEG is normal, it is highly unlikely that they have seizures. And many neurologists will actually decline to actually see those kids because if they're just staring, they have a normal EEG. That's not, it's not epilepsy. So generalized tonic-clonic seizures. As I mentioned before, the tonic phase usually is the first bit where they get stiff, and then they can get the rhythmic jerking for the next few seconds. The frequency of these can be highly variable. So some kids will do them multiple times per day. Some kids will do them once in their life. Other kids will do them once every few months. Often worse when the kids are sick. Sleep deprivation can trigger them. Rarely flashing lights can trigger them. I certainly think a lot more people worry about the announcements on movies and TV shows and video games that photic stimulation is going to trigger a seizure. That's pretty uncommon for all epilepsy types in particular. The postictal, they will be often tired for at least a few minutes, if not a few hours. I've even had some kids tell me that they don't feel cognitively quite right for the rest of the week, that they just have a harder time with things like math or remembering words or subtle findings. Generalized tonic-clonics can start at any time, but certainly, as I've mentioned before, the teenage onset should make you worry about, is this an epilepsy syndrome? And many of the teenagers will have myoclonic seizures preceding their convulsion, but the parents just didn't realize that those were seizures. Here is a child who's going to jerk as they have a sort of myoclonic start, and now they're stiff in both arms. She's fussing and crying, and she is stiff, so therefore still in the tonic phase. And then as it goes on a little bit longer, she's going to start shimmering a little as the muscles start to contract more rhythmically. And then she's going to go into the clonic phase where she is jerking now. So that has gone from tonic to clonic. Myoclonic seizures, I just mentioned, each seizure is less than a second, but they often will have clusters of seizures. They don't lose consciousness with them. That body jerk often happens in the morning. So dropping or flinging things, often the toothbrush, if they're brushing their teeth in the morning, it'll fly out of their hands. Kids walking to the breakfast table with their cereal bowl will all of a sudden drop or throw the cereal bowl. So asking about things like that, because like I said, the kids who have convulsions, also in retrospect, having had myoclonic seizures, particularly, like I said, first thing in the morning, sleep deprivation is a real bugaboo for these kids. And if you're going to talk about photosensitive epilepsy, the myoclonic seizures are actually the most common seizure generated by strobe lights. Again, they don't have a postictal, and this is most common in teenagers, although certainly young children usually have them, but those kids usually have other seizure types too. Here's a young kid with a subtle jerk. And so with young kids, it can certainly be missed. Like I said, with teenagers, it's usually something you find out with the sort of retrospective diagnosis from the convulsions. Atonic is the lack of tone. Sometimes these are called drop seizures. They're also like the myoclonics, just boom, and a sort of an electric zap. And they can have a myoclonic jerk first and then fall. Usually you can't tell that until you've got that on video. And the drop seizures are really problematic because it can break their teeth, it can break their jaws. Lots of these kids will end up wearing helmets. Unfortunately, it's hard to get good helmet protection under the jaw. And so a lot of the kids have helmets that don't actually prevent the injury. And so that is a tricky thing. And some parents see the helmets as very stigmatizing. Most of the time, you can't figure out when they're going to happen or what caused them to happen. And then certainly early childhood onset is classic. Most of the kids will have other seizure types. There are kids who have drop seizures alone, and that is problematic. Here is a kid who is sitting and then boom, loses tone and just hits the bed like a sack of bricks, just boom. And so that's where you can certainly imagine that if the child were standing up, causing significant injury, particularly if they weren't in a bed or a crib with a pad. Focal seizures, as I mentioned, really common in under a year of age and certainly more common as we become older. The seizures can look like a lot of things, and it depends on which part or which focus of the brain is where the seizure starts. The longer the seizure goes on, the more likely it is to spread from one area of the brain to other parts. If it spreads to the whole brain, we call that secondary generalization. The variability is really tricky, often starting with automatic behaviors like the lip smacking, finger picking. They may have an aura or a subjective sensation of it starting, certainly using yucky words like the French déjà vu. They feel like they're in a place that is familiar, even if they haven't been there in the past, or the opposite, jamais vu, where they're somewhere familiar, but it seems unusual. They can have epigastric rising as feeling like their stomach is rising in their chest. They may smell things. So all kinds of subjective sensation. With the motor component, it's really helpful if we figure out where does the head and the eyes go to, because at the beginning they may twist to one side, but then as the seizure spreads, then the head may come back to midline, and that's often when the eyes roll up in the head. They often spread from either face down to the arm to the leg. Before going to the whole body, they can actually go in the opposite direction, going from the leg to the arm to the face. And that has to do with how the brain is organized. And that's, some people call it the Jacksonian march, although I don't like using dead white guys' names for most syndromes. Also, more common when kids are sick. They can be postictal for hours. And the classic thing is that if their weakness is the part of the body that the seizure started in, that can really help you know that this is a focal seizure, because it's very unlikely for children to have strokes. If they have convulsions and afterwards are weak, it's much more likely that this is an after seizure weakness, where the part of the brain that had more seizure takes longer to get back to its normal function. And so having a kid with a drop of an arm, a kid who can't move their leg after the seizure that slowly improves over the next 10, 15 minutes is much more likely to be a post-seizure phenomenon than due to a vascular problem. Seizure workup. Video has gotten so much better, as now pretty much every parent has a phone that could record it. So seeing the seizure is really helpful both for you and ideally you have a relationship with the neurologist where you can send them video and they can look at it and say like, yes, I'm very worried about seizures with that. Getting an EEG is certainly the test of choice. A standard is usually just half an hour to 45 minutes. If the kid is developmentally typical, they should all get sleep-deprived EEGs. I certainly think that with kids who are on the autism spectrum, sleep depriving them is both mean to the child, mean to the parent, and arguably mean to the EEG technologist who's going to have a harder time getting the wires on. So for the developmentally challenging, behaviorally challenging kids, letting them get normal sleep so they're more likely to tolerate the wires going on is definitely the way to go. Some groups will do prolonged outpatient EEGs. Sometimes that needs to be inpatient. So that's something that depends on, do you need to actually capture the event or can you get enough information from just an outpatient one? I strongly discourage sedated EEGs because the medicines we would need to sedate the child enough to get the wires on their head mean that the brain electricity is fairly meaningless. It just looks like they're on a bunch of drugs. It seldom changes the outcome. So I certainly think that if the family wants an EEG, but they're convinced the child needs to be sedated to have it done, it definitely makes sense to just send them to a neurologist and they can have the conversation of, is it going to help? Because it usually doesn't. Imaging is not something that most kids with epilepsy actually need. Certainly, if they have focal symptoms, then yes, imaging is helpful. But most of the time, imaging can be delayed until after they've seen a neurologist. MRI is certainly the preferred modality, but almost all kids are going to require sedation, certainly in the younger cohort. And that's not something that's trivial. And CT is something I discourage because it really only shows, has there been blood in the brain or fracture? Usually, particularly pediatric centers will reduce the amount of radiation in the CT so as to reduce the likelihood of causing cancer, but that also reduces the ability to see the brain tissue well. But the pediatric centers know that if you want to see the brain tissue well, you need an MRI. So even the kids who get a CT done, which often happens in the emergency room, they still end up either needing an MRI to actually answer the question if there's a focal seizure, or they shouldn't have gotten either imaging in the first place if the seizure was whole brain at onset. So EEG is something you guys should be ordering, and imaging is, like I said, something that you really can hold off on. While many parents will worry that they're having seizures because of a brain tumor, it's very, very, very unlikely. And if they are having seizures due to a brain tumor, it's likely to be a focal seizure. So seizure risk factors, certainly I always try and figure out, does this child have an abnormal brain that's more likely to have a seizure? So that could be because it was physically injured. So penetrating brain injury is certainly much more worrisome than blunt head trauma. Abusive head trauma, formerly called non-accidental trauma, is likely to involve both a shearing injury and microscopic bleeding and is worse than head trauma from things like car crashes. Certainly the physical injury has to be quite substantial. Lots of families say, oh, my child hit his head when he was learning to walk, and that is normal, and that is why we have skulls that are very good at protecting our brains from getting injured. So serious injury to the brain, like things that would cause them to be unconscious for quite some time, usually those kids end up in the ICU. It is not usually subtle head injury that causes seizures. Ischemia, certainly perinatal stroke, and then the kids who've had drownings or near drownings do have a lot of ischemic injury to the brain, and those kids will have seizures, sometimes symptomatically due to the injury, and then often later as remote symptomatic epilepsy. So as I mentioned, the brain not growing right from the get-go is more common than tumors insofar as causing seizures in children, but lots of parents are afraid of brain cancer, but it is very uncommon. If you're going to get brain cancer, it's more likely to cause posterior fossa problems like vomiting and headaches rather than actual seizures. You're not going to find out about the genetic syndromes unless the kids are developmentally not right. And while family history is important, the vast majority of kids with people with epilepsy who are born to, the vast majority of children born to people with epilepsy don't have seizures. So just because the parent has seizures doesn't mean the child will. It's very unlikely if it's only great aunts or second cousins or things like that. And as I mentioned, asking about developmental history, because that really lets you know, is this a high risk cohort or not? Some seizures are just symptoms of things going on. And so febrile seizures we've already talked about. tied to that, like I said, meningitis or encephalitis, infection in the brain, you can have seizures because your brain is infected. And really what you need to deal with is the infection of the brain and not the seizure itself. Gastroenteritis, bizarrely, has rotavirus as a virus that triggers seizures. I don't know if we're going to see less of that now that rota is getting immunized for. And then from a pediatric board's perspective, knowing that Shigella or Salmonella can make a Shiga toxin that can cause bloody diarrhea, and those kids will have seizures often because of the toxin. Again, what you really want to worry about is the infection of their intestinal tract bad enough that you need to treat that. Symptomatic seizures right after a head bump is pretty common and not usually worrisome. Things like electrolyte abnormalities or sugar abnormalities, usually this is something that I worry more about the endocrinologic background for it. We don't deal as much with intoxication and ethanol withdrawal in young kids, although certainly toxidromes happen when kids have ingestions. A lot of the encephalopathies are going to be more common in adults than they are in kids, so I'm not going to focus on that. The good news is with symptomatic seizures, you don't really need to worry about the seizure as much as the underlying disease. Some, though, will predispose the child to seizures in the future, and that's, like I said, the bad traumas. And then some diagnoses, like febrile seizures, may only be clearly accurate or inaccurate retrospectively. So is it a seizure with fever where the kid had epilepsy? Or is it a febrile seizure? And that is part of the tricky realities of brain diagnoses. So seizure mimics, I want to go through pretty briefly. I did write up some descriptions for people to read through if you want to think about more deeply. So sleep myoclonus, everybody does them. The jerks, if you have a co-sleeping partner, you've noticed their sleep myoclonus and they've noticed yours, but it can be really traumatic in the young kids. Some kids with reflux will be stiffening or getting dystonic twisting type movements that are worse when they've been fed, particularly if they've been fed and laid down. And it can be dramatic. And this is something where video is really great for sorting out. Does that look more like reflux associated movements versus epilepsy? Syncope is something where most people will feel it coming on. They'll feel either faint or have their vision get brown or have it tunnel out, which is usually different from the auras that focal seizure patients will have. Kids who have syncope usually don't bite their tongue or pee on themselves or poop on themselves, whereas those can happen in epilepsy. Convulsions can happen with what we call convulsive syncope, where the brain is not perfused with blood. They lose consciousness, they hit the ground, and then they jerk at the end. Whereas if there's abnormal movements with seizures, it usually happens before or simultaneous to the loss of consciousness. Syncopal patients tend to get pale versus red in the face. Again, the cold and clammy versus hot and sweaty. The duration is usually short for both of them. And then the after event thing is that most kids with seizures who've had an event like this, they're going to be postictal for longer than the kids who have syncope, unless they're having persistent heart abnormalities, in which case I say, if you're worried about syncope, getting an EKG is much more helpful than getting an EEG. The brain electricity is almost always going to be normal in syncopal patients. And quite honestly, if it's abnormal, it may not have anything to do with their syncope. The big thing is that you can also get a story of if they sat down and they aborted it, then that makes you think that that's not a seizure because you cannot stop seizures. So again, the convulsion is one thing to think about, and the preventable or interruptible nature of syncope. Breath holding is something that happens in the same sort of time span as febrile seizures. Some of the kids get blue, some of the kids get pale, but either way, they're going to lose consciousness and sometimes have abnormal movements, particularly the cyanotic kids will often cry at the beginning before they get blue, often triggered by them being angry, having toys taken away, things like that. Whereas the pale kids is more often usually triggered by pain, and these kids are more likely to have urinary incontinence than the blue or cyanotic breath holders. Psychogenic or psychological behavioral stuff. Certainly everybody stares. I think the kids with ADHD stare more than most. So that can be overinterpreted, particularly by teachers. Same thing happens with kids who have intellectual disability. Intellectually disabled children who are just staring, it's almost never seizure. And even if it is seizures, do you really need to treat it is much more nebulous. I really much more worried about other seizure types in kids with intellectual disability. And certainly kids under 6 months, it's not seizures. If it's staring alone, it is very, very rare, meaning you'll probably never see one in your practice for a kid to have onset of pure absence seizures under 2 years. So really, staring is something that mostly should be met with reassurance in the young child. And EEG certainly should be considered in kids who are 3 and older and having staring spells, but they should really fit the description of multiple per day, not one every few weeks. Infantile masturbation, sometimes called self-stimulation syndrome, can have movements that can look like seizures. They can be stiff, they can posture, they can grunt, they can rock, they can get red in the face. Often they are trying to get their genitals to be rubbed, often in sitting in a high chair that has something between their legs, but they'll often, if they're not in something with an external object touching their groin, they'll often cross their legs as they're trying to get this going. These kids are fine. They just do it. They usually start when they're a couple of months old. They usually outgrow it before they get to school, and parental reassurance is the key. So some people call psychogenic, non-epileptic things seizures, and I feel like if you use the word seizure, you're going to get the idea of this is epilepsy and this is hurting their brain in a way that I prefer to describe them as spells, because they are spells that happen. They can be very dramatic. The movements look different to a trained eye, and this is where video is key. But classic things would be like flopping back and left and right, getting a little bit worse, getting a little bit better, then getting worse again is something that doesn't happen with seizures. Seizures tend to build to a crescendo, then get better, and then they're over, and follow a more regular pattern, whereas psychogenic events can be quite irregular. The vast majority of psychogenic patients will have their eyes forced closed, whereas 90% of seizures, the eyes are open. So what are they doing? Are they resisting you? A diagnostic thing, as I mentioned, the video is key. Some patients need to have an EEG with it, but often the video can be fairly convincing. And then after the spell, if it's psychogenic, often you can hold their hand above their head and let go of it. And a kid who's postictal from an actual seizure will just have their hand drop and then just land, boom, right on their face. But the kids with psychogenic events, it will always just sort of go to the side of their head because they're basically controlling their arm well enough to make it not hit their face. Psychogenic events in kids are almost always conversion disorder. This is a subconscious manifestation of some stress that they don't know how to put words to. It is not kids trying to get out of school or get out of things. So the idea of malingering or faking it is really not appropriate for children in the vast majority of cases. That is something where your neurologist and your psychologist or psychiatrist should be digging into things to say, is there a secondary gain here or not? But I do think that these are uncontrolled and children can't just stop them, and they really need more talk therapy than anything else. So tics are semi-involuntary, meaning that they can suppress them for a while, but they're likely to come out eventually. The movements are often preceded by being able to feel that they need to do it. It's like a compulsive thing, and there's a lot of OCD type symptoms in kids with tics. Some kids have just motor tics, some kids have vocal tics, some kids have mixed, and if you have both of the types and it goes on for a year, yes, you can call it Tourette syndrome, although that's not usually particularly helpful. It's just saying, hey, you've got a tic disorder. Similar type movements in kids that are often intellectually disabled, some of which can be self-soothing. We call those stereotypies. So the big difference between tics and stereotypies is the tic kids can describe them to you, whereas most of the kids with stereotypies can't. The stereotypies often are also more of an emotional overflow thing where either they're too stressed out or they're so happy that they're going to do their hand flapping, they're going to do their fidgeting. The tics and the stereotypies don't hurt the kid unless they're ticking so badly that they actually get muscle soreness. Really, tics most often stress out the parents, stress out the teachers, and I always make it very clear to families, I'm not going to treat a tic because a parent or a teacher doesn't like them. I'm only going to treat a tic if the child says, I don't like this so much because it's really making me uncomfortable at school, I'm having issues, that I want to take a drug that's probably going to have side effects, it's probably not going to make the tics go away, but it might make it a little bit better. So generally what I do is counsel for tolerance of the tic behavior and reassurance that they're not hurting the person. So in summary, seizures are going to be the stereotyped events that happen, uncontrolled electrical activity in the brain, can be convulsive or positive, uncontrolled movements, or it can be negative and interruption in cognition, or some of both. Again, the tonic is the stiff one, the clonic is the rhythmic jerk one, the myoclonics are the single jerks, versus the atonic is the opposite of that, of falling down. The non-responsive absence is different from the hypomotor focal seizures, where the kids may also stop their behavior, but the hypomotor focal seizures usually are a lot longer and can progress into movements like stiffening and rhythmic jerking in a way that absence is just the staring only. Anybody who's had multiple unprovoked seizures has epilepsy by definition. And again, EEG, very appropriate for you guys to order. I encourage you to hold off on imaging unless there's clear focality. So with that, I'm happy to go through some scenarios. For those of you who did my infantile spasms one talk, I was able to do that. Unfortunately, I'm having issues reading the responses, or if people want to just do question and answer, I'm happy to do that now as well. Chat. No, now I can't see the chat. I don't see anything in the chat. So if anybody wants to vote for, or if anyone has questions and wants to put them in the chat now, I can see that. For some reason, I can't see the Q&A, but that's probably
I
because of
do see a hand raised, Dr. Ray. I can unmute her.
Ruby.
Yes. Let me do this now. Okay.
Hi, my name's Laura Holland. I'm actually a gynecologist, and I'm here for a personal reason. I have a grandson who at the age of 2 just had a second tonic-clonic seizure. The first one was febrile, and the second one was not. So at the age of 2, he has a diagnosis of epilepsy, and I have 2 questions. One, I'm wondering what the prognosis is. He's had a negative EEG and a negative MRI. He hasn't seen the epilepsy pediatric physician yet. I'm wondering what the prognosis is for him. He is developmentally meeting all his milestones. And then I have a more very specific question. He was started on Keppra, and we have a family history of schizophrenia. And I was reading about it, and it kind of scared me. Although the neurologist said that, if the kids develop any psychogenic symptoms, we can always stop it, but it's really the best thing for children's epilepsy. So,
I mean, I certainly think a quarter of kids with levetiracetam, generic for Keppra, are going to have behavioral problems. Those have always stopped when I've stopped the medicine, so I've never seen it cause persistent psychological problems. So I certainly think that if he's a total fuss bucket, then he is fitting into the quarter of kids where if you type in Keppra to the internet, usually rage is the next word that pops up on the internet search. So certainly if he becomes a handful, I would certainly see that as very, very common. But again, I don't think that long-term psychiatric stuff is likely to be caused by levetiracetam. As to the prognosis, I mean, most kids who are neurotypical before the seizures tend to be neurotypical afterwards. So I certainly think that that is the most promising thing. So I certainly think that, yes, if there's a second seizure, then epilepsy is a fine word to use for it. But the normal EEG does not mean that the child does not have seizures, does not mean that the child does not have epilepsy. It is certainly more likely to have a normal EEG in kids with focal epilepsy than in kids with generalized epilepsy. But if he's already had head imaging, then that's certainly reassuring as well. So in general, I would say reassurance, 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 and hope that his behavior's not really bad. But if he's been on the levetiracetam for more than a few weeks, the behavior problems would likely have presented themselves.
Do kids grow out of this, or
Absolutely.
is it okay?
Yes, yes. Kids being much better patients in general than adults, and yes, many children outgrow their seizures, and there's semantic differences whether or not the epilepsy is resolved versus is in remission, and a lot of that is beyond the scope of this talk. But yes, many kids will outgrow the seizures and go on to be very, very happy, normal, typical kids.
Yeah, I mean, it's interesting, the rage part. I mean, he's a 2-year-old. He's like a very difficult 2-year-old, like most 2-year-olds are. So I don't really know if the Keppras changed that.
I personally use levetiracetam a lot more seldom than a lot of general neurologists. Slap it on kids, certainly emergency room, slap it on kids because it's generally fairly well tolerated. But no, it is a medicine I prefer to come to later rather than first.
Oh, really?
Yep.
Okay, interesting. Thank you.
Sure. Other questions, other concerns? Well, I do have, like I said, some scenarios. So if you people want to type into the chat, if you're willing to take the risk of showing, okay, here's a staring spell. Oh, no, sorry. So the scenarios I was going to have people type in Y for yes, you think it's a seizure, or N, you think it's not a seizure. And if it is a seizure, do you think it's a simple febrile? Do you think it's infantile spasm, one of these seizure types? Or no, what are the sort of things on the differential that we talked about? And again, feel free to type into chat because I can see that. Any questions, if you have them, rather than your answers to these scenarios. So here's a 9-month-old normal delivery, so making our OBGYN happy. And about once a day, we'll stare, usually about 10 seconds. Nothing seems to make it better, nothing seems to make it worse, and the kid's not doing anything else. So seizure yes, seizure no. YN. I'm not seeing any chats. So this is certainly something that is much more likely to be the concern of a first-time parent who is worried that their child may be having seizures, and they may have a family history of seizures. But in a child this young, it is vanishingly unlikely to be epilepsy. It's way too infrequent. And again, there are no other seizure types. So I would discourage getting an EEG because some EEGs are just abnormal and would have nothing to do with this child staring. Staring in an 8-year-old who had brain injury and was in the ICU for a couple of weeks. All special education classes, but during certain classes more than others, he'll stare, usually for 15 seconds. This to me is more likely a kid who is either just having cognitive processing stuff and not having seizures, but often the teachers will express concern that you need to get this child checked out for seizures. And the answer is no, you don't. If it's this infrequent, if it's much longer than an absence would typically be, if it's 15 seconds, certainly if it's 2 minutes of staring, that is not seizures. And so I certainly think that the important thing with staring spells like this would be reassurance. Whereas this 6-year-old, 10 times a day, 10 seconds long, that is something that is absence epilepsy. And so that is something where, like I said, they will not come in saying that they're exacerbated by hyperventilation, but you can definitely get the story clarified by doing the hyperventilation yourself and be able to say, yes, this child has epilepsy. Convulsive spells. Felt the room go black, lost consciousness. Then after a few seconds of being unconscious on the floor, then started jerking. Has only happened twice, one of which happened after he had blood drawn in your office. Seizure yes, seizure no. This certainly as a trigger is not a trigger for seizures. It's definitely a trigger for syncope. And certainly the feeling the room going black is something that is classic for syncope. So this is something that does not need an EEG. Even though they convulsed at the end, it's almost undoubtedly that they did not perfuse their brain because of either the stimulus response to the blood draw. Certainly, for some kids, it's standing up too quickly and they're going to not perfuse their brain from a cardiac perspective. And again, EKG or heart electricity is more helpful in ruling out badness in kids who are syncopizing than EEG, which is almost always normal. And then the head jerking. A kid is feeling that some head jerk coming on. It more often goes to one side than the other side. It lasts for about 2 or 3 seconds, then can recur again later after a few minutes. Never loses consciousness. On a bad day, he can have 5 of them. On a good day, he might not have any, but he's much more likely to do them when he gets home from school. Seizure yes, seizure no. This is a tic. And so the feeling them coming on, sometimes kids can describe that in epilepsy as an aura. Unfortunately, most kids who are even cognitively typical kids, when they have their first tics, they often can't really describe their premonitory urge. It's much more common that you hear that from teenagers, but if they start having their tics when they're 4 or 5 or 6, then they're really not going to be able to give you that history, which is too bad because it really does help seal the deal for the diagnosis. But again, videotaping this can be really helpful to say that just looks like a tic. It does not look like a seizure. And these kids need reassurance. And as I said before, I try not to treat them because really it's not going to work. It's never going to have a kid with tics go down to 0 tics. They're going to have fewer tics. They might have them less at school, and so they may feel less social stigma, but they certainly are not likely getting meaningful improvement other than their sense of self and how they feel that they are treated by their peers. So again, thinking about what seizures are, they're definitely stereotyped in certain ways. The kids who have them most of the time are normal, both before and after the seizures. And we look like idiots, as I said, because much of epilepsy is idiopathic or unknown cause. The workup that I mostly want you guys to do is to get them on EEG. The treatment goal would be for children to be seizure-free. I didn't want to get into the treatment options in this talk just because we're trying to really focus on the bread and butter of the beginning. But again, if you want to type questions into the chat, I'm happy to answer them. Or if you want to raise your hand and we can let you speak. And with that, I think we are done. Did I talk faster than I usually do? Apparently. Well, if nobody has any other questions, I'm happy for you to have a few more minutes left in your day. Jennifer, are you seeing anything in the...
I do not. I am going to put some things in the chat.
Okay.
And of course, I'm having some technical issues right now.
I get in here if I can see the...
Yeah, I don't
Oh, yes,
see
now
anything.
I can see the Q&A. So I don't see any Q&A.
Yeah, I didn't see any in the Q&A either. I'm going to put these in the chat too, but I'll just say them verbally. But thank you so much for everyone attending today. I just want to remind you that the CME survey will appear in a tab when you close out of this webinar. We really appreciate you taking the few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts. And then I'm going to put one other thing in the chat.
And particularly if the people have other talks they would like us to give, there is a list of a couple of them in the web portal. Oops. I certainly just gave a talk on motor delay or disability. Happy to give that again, or hopefully soon, MAVEN will be able to give you CME credit for watching pre-recorded lectures. I think that's supposed to be rolling out soon.
Yes, we're getting there.
So if you missed the infantile spasms talk that I gave a little bit ago, wait until we give you CME credit for it and watch it then.
Yep.
Or watch it now for your own edification. No CME.
Yes, I did add about education sessions. So we hope you enjoyed today's session, or interested in attending future sessions, or even anchoring an educational session. All clinics can anchor an educational session, which means you get to pick the topic, date, and time of an educational session. The only requirement is that someone from your clinic attends this session. If you're interested in becoming an anchor, we would love to schedule your session. You can either submit the educational session request form on the clinic portal, or you can email ktalbot@mavenproject.org. That's Kristen Talbot, and I did put that in the chat. So yeah, we have 1 minute left. If anyone has any questions or wants to put anything in the chat, we're here for a minute. All right, well, thank you, Dr. Wray. I thought this presentation was wonderful, and I hope you have a great rest of your day, and I hope everybody that attended has a great rest of your day.
Thanks so much.
Okay, bye. Thank you.